You know, we've come to an interesting time in the history of pain management, and I think we're going to look back on this and all kind of either shake our heads or shrug our shoulders. We have a molecule, a drug, that comes from a plant, the same way many of our therapeutic agents do, which for the right patient is a very effective treatment. Each and every day I have patients in the office who say, but why are you stopping my medicines? Or why won't my doctor write these medicines? Or I don't understand why I have to lower my doses. And tell you the truth, I don't have a good answer for them other than politics, other than rhetoric, other than the landscape that there are certain people who are predisposed to abuse and misuse, and certain people who force themselves to abuse or misuse, and there are unintentional deaths related to this class of medication. But what we fail to recognize is that it's a completely separate domain, a completely separate population than the patients that we're trying to treat. So to rob or starve the patients of a therapeutic class of medicine, which is effective, because there's another class or population or another domain who's abusing the medicine, is just a travesty, and patients really are going to suffer until the time comes that we have analgesics that are effective with a tolerable side effect profile. The topic of my discussion at PAINWeek here this year was analgesics of the future, because as a clinician on the front lines, it's all we have to look forward to. Each and every year for the last decade or longer, we've been talking about the troubles and the challenges with opioids. And they are a challenging class of drug. On the one hand, they're great at treating severe levels of pain. They may be the only class of medicine that works for severe pain. But there's a lot of baggage associated with opioids, both bothersome side effects. Go around the conference and you'll see talks on opioid-induced nausea and vomiting, opioid-induced constipation, opioid-induced endocrine changes, opioid-induced hyperalgesia, opioid-induced bad things. But you also see data on opioid-induced good things like pain relief. So when you look to the literature, and PAINWeek has been great at letting the scientists and the pharmaceutical companies that have products in development come and display their posters and their works about the drugs that are in development. We see that there are non-opioid molecules in development, nerve growth factor inhibitors, a lot of excitement around the NGF class of drug, not just for one type of pain, but for multiple types of pain. When I say multiple, I mean osteoarthritis, neuropathic pain, low back pain, even things, other areas outside of pain. There are non-opioid molecules that are anti-inflammatory like. We've learned about some of the biologics in things like rheumatoid arthritis and Crohn's disease. There may be some biologics that are useful for pain. And there are opioid-like molecules or kind of newer opioids which can selectively provide analgesia without the respiratory depression, without some of the side effects, without some of that baggage of opioids. And part of what I tried to do this year at PAINWeek was let our audience of clinicians know that, hey, we're in a tough time right now, but the cavalry is on the way. We have newer medicines coming. We have effective therapeutic agents that we could look towards the future. Is that future 2 years or 20 years? I don't know, but in the timeline of man, it's a short time until we have novel therapies that work for pain.